So here we will continue our talking, and at this part, we will talk about dementia versus delirium. We'll go very quickly through some types of dementia and its diagnosis. So, what's the difference between dementia and delirium? So, dementia is an acquired cognitive decline. It's sufficient to result in social or occupational impairment. So, what we call it difficulty in performing the activity of daily living. And we have basic and instrumental activity of daily livings. However, normal aging can cause a gradual cognitive decline, but it's differentiated from dementia by the degree of cognitive impairment. Always when we assessing a dementia patient, we should do a screening for major depression because it's resulting in poor attention that cause impairment of immediate recall, while short-term memory is preserved. So depression, sometimes it's called pseudo-dementia. So we should make sure and be careful of mixing the depression with dementia. What about delirium? So what's the difference between dementia and delirium? Delirium is a waxing and waning, so meaning that the patient is having fluctuation during the day with impaired attention, while dementia is a steady cognitive impairment. So when we are suspecting delirium, so when an elderly patient presented to the hospital with some metabolic derangement, some infectious etiology, and you find the patient sometimes doing well, sometimes deteriorating in terms of attention and level of awareness. So before the patient labeled as dementia or the stage before that, we have what we call it mild cognitive impairment. And it involving deterioration in one or more of the cognitive domain, but it's not severe enough to classify the patient as demented. And it's not interfering with the daily activity, what we mentioned. What the meaning of daily activity? So activity of daily living, meaning like bathing, toileting, showering, preparing food, go for shopping, driving, ambulation, working, all these, the activity of daily living. At this stage, usually it mainly noticed by the family and friend. So we have amnestic, what is involving mainly the memory, and we have non-amnestic involving other cognitive domain like executive function, visual spatial, language, or behavioral symptoms. So the Alzheimer's disease is one of the most common cause of degenerative dementia. It's caused by loss of cholinergic neurons, which is causing decrease in choline acetyl transferase and causing impaired cortical cholinergic function. And dementia have different other types other than Alzheimer. We have dementia of Lewy body, which is presenting with fluctuation of cognitive impairment, but here it's associated with visual hallucination, Parkinsonism. We have other called frontotemporal dementia. They will have either behavioral changes or language involvement. And we have what we call it vascular dementia. When the patient have a lot of vascular risk factor, they might develop with more and more strokes. They might develop lost the cognitive function and develop dementia. So now we'll talk about multiple sclerosis. So MS is a chronic autoimmune inflammatory disease. It affecting the central nervous system. It attacks the myelin of the axon in the central nervous system and delay the impulses in the brain. They have a typical syndromes, including optic neuritis, brainstem syndrome, like internuclear ophthalmoplegia, trigeminal neuralgia, cerebellar syndromes, and transverse myelitis. So when we are saying an attack or MS attack, so it's a neurological disturbances, and it should be lasting at least for a 24-hour in absence of other fever or infection that explaining this neurological deficit, and it involving any of the the area that mentioned before. So in 2017, the McDonald criteria described the attack as either. So we have here the number of the clinical attacks. We have the number of lesions with objective clinical evidence, meaning, for example, if the patient have a sensory symptoms in the left upper limb, the MRI feature showed definite lesion in the right parietal, explaining the symptoms. Okay, what about if we have two or more clinical attacks with two or more lesions explaining this attack, so we don't need any additional information to diagnose multiple sclerosis. What about if we have two or more clinical attack, we have one clearly presenting lesion, and the other is historical evidence, meaning that a distant lesion in a different area, however, it's documented clearly that it has an attack. The third category, that we have two or more clinical attack and we have only one lesion explaining the objective clinical evidence. So the explanation of the objective evidence could be either through MRI or the physical examination. So for example, we have the weakness, the objective clinical weakness. So in this time, we need what we call it dissemination in space. And in the next slides, we will talk about that. If we have one clinical attack and two or more objective number of lesion, we need what we call it dissemination in time. And again, we will talk about that. If we have one clinical attack and one lesion, we need both dissemination in space and time. So these are the objective clinical evidence. So for example, we have in physical examination, what we call relative afferent pupillary defect. So when I examining the patient pupil, I noticed that initially there is constriction, then dilation, then it's dilated more and more. That's because when the impulses trying to travel through the axon, because of demyelination over time, it will be not responding. So this relative afferent pupillary defect suggesting optic neuritis. Internuclear ophthalmoplegia presenting in a patient with diplopia. Hemisensory with a patient of myelitis, and so on. So the objective clinical evidence with clinical examination or MRI related. Also, we can find it with other, as we mentioned, either with evoked potential or imaging. So dissemination in space, where are the areas that we are looking in MRI for dissemination in space? We have what we call it juxtacortical or cortical juxtacortical lesions. So these are the cortical juxtacortical lesion. We have the periventricular lesion, and this is what we call it Downson fingers. We have infratentorial lesions, meaning in the brainstem or the cerebellum. And we have spinal cord lesions. So these are the four areas that we look for in dissemination in space, and the presence of at least one T2 lesions in two of these areas indicating dissemination in space. What about dissemination in time? So it's characterized by a single MRI that we have in this MRI, gadolinium enhancing and non-enhancing lesion. Okay, so we have a lesion that taking the contrast and lesion not taking, or the presence of new T2 lesions, so that when we compare it with a previous MRI. Okay, so dissemination in time, meaning more of MRI presence with GAD, with contrast, and presence of gadolinium enhancing lesion and non-enhancing lesion at the same time, or in the follow-up MRI. The other dissemination of time criteria that's helpful, the presence of oligoclonal band in CSF. So we do LP, send for oligoclonal band, and it come positive. What about primary progressive MS? Primary progressive MS is either prospective or retrospective of 1 year of disability, progressing disability, with two of the following criteria. Either one or two T2 lesions in any of the periventricular, cortical, or just a cortical or infratentorial, not including spinal cord in this part, or two or more T2 hyperintense lesions in the spinal cord, or the presence of CSF oligoclonal band. What about the management? So during the acute attack, we should give the corticosteroid, the IV methylprednisolone. ACTH can be given, or plasma exchange. So the first line therapy is corticosteroid is the principal treatment. We will give 1 gram IV for 3 to 5 days. ACTH is compared to corticosteroid is not, the evidence is not well defined, and plasma exchange is depend on the underlying severity of the attack. After that, we should decide for the second line therapy, which is depend on the severity of the attacks. We call it disease-modifying therapy. So since 1993, we have more and more DMTs for multiple sclerosis. Now we're going to move on to epilepsy and status epilepticus. So when I have a patient with first-time seizure, so what should I do? So approaching a patient with first-time seizure, first we should know, is it a spell? The spell that the patient presented with is a real epileptic seizure, or it's the event, the whole event? Is it a really seizure or other kind of syncope? So this is the first question I should ask myself. It is really an epileptic seizure? Is the if the event is epileptic, is it likely to recur? So the stepwise approach, is it a seizure or not? Is it epilepsy? What kind of epilepsy, and what is the underlying etiology? So what's the meaning of, is it really seizure? So I should ask the patient about the semiology of the event. So is there any pre-ictal phase? What is the ictal phase? What is the post-ictal phase, to differentiate it between cardiac syncope, psychogenic event, vasovagal, or any other reason of this event. After that, if it is a single seizure or it's occurred multiple times, but the patient at that time either didn't know or not well evaluated, and if it is really epilepsy, is it generalized, some types of generalized epilepsy or focals, and is there any underlying etiology? So when approaching the patient of first-time seizure, first we should make sure, is it provoked or unprovoked seizure? So what the meaning of provoked seizure? Provoked seizure due to underlying either, for example, hypoglycemia, drug intoxication, electrolyte disturbances, uremia, or any other provocative factor, medication, as we mentioned, medication intoxication, like some form of stimulant. After that, after we make sure of the history, sending the lab, we should perform neuroimaging. So either brain MRI or CT or brain, according to, CT or MRI brain, according to the availability. And EEG is a must in first-time seizure. So the EEG always preferred to be done in the first 24 hours. However, if it is normal and the still seizure is likely, we can perform sleep-deprived EEG. So after that, we counsel the patient according to the result. If the neurological exam is normal, EEG is normal, MRI normal, and it's confirmed as a first-time seizure, we usually counseling the patient that the risk of having recurrence range between 20 to 40%. So we might not start anti-seizure medication. However, if any of these three came positive, so the risk of having another seizure up to 80%, so we should initiate anti-seizure medication treatment plan. So in 2017, there is a classification for seizure types according to the onset. So either we have a focal onset, generalized, or unknown, or unclassified. So unclassified, when the inadequate information seen. Unknown onset, when the onset of the seizure it's not witnessed. And the focal, meaning that either we have motor or non-motor symptoms. And the focal seizure, we should after that make sure if the patient was aware during the seizure or there was impaired in awareness. We say focal aware seizure or focal aware onset when the patient is aware along the whole seizure, epileptic episode. If there is at any time point during the seizure impaired awareness, so this is, we call it focal onset with impaired awareness. So if it is motor onset, what's the meaning of automatism? Automatism is non-purposeful repetitive movement. So for example, the patient doing like if they're buttoning their shirt, they are looking for something. So it's non-purposeful repetitive movement. What about atonic? Atonic meaning that when the patient sustained any posture and all of the sudden lose the tone of the muscle. So for example, either the hand drop, neck drop, or the whole body. So it's sudden loss of the tone of the muscle. What's the meaning of clonic and what's the difference between clonic seizure and myoclonic seizure? So clonic seizure, usually it's more of distal movement of the hand. It's repetitive, some sort of rhythmic movement involving distally more in the hand. Then it progressed to involve either bilaterally or even the lower limb. However, the myoclonic seizure more started proximally and it's an arrhythmic shock-like movement. What about tonic? So what's the meaning of tonic? So tonic is sustained agonist and antagonist muscle contraction, so resulting in sustaining the tonic posture. So this can be either focal or can be generalized. So in the generalized, we have the motor and non-motor. In the non-motor, the generalized onset, we call it the absence, which is like pace of the surroundings. So the patient will have loss of the awareness of the surrounding. Here is the EEG for a patient with idiopathic generalized epilepsy. And here's for a patient with absence, so rapid onset and rapid offset. And we have the typical childhood absence epilepsy, which is classically unresponsive for short duration associated with some sort of eye fluttering or automatism. Usually it started in the 4 to 8 years with 4 to 8 years of age. And you can provoke this seizure in the office with hyperventilation. And the treatment of choice for that is ethosuximide if it is not associated with any generalized tonic-clonic seizure. Otherwise, we can start valproic acid, lamotrigine, or levetiracetam. One of the most important and the second most common after stroke is status epilepticus as a neurological emergency. So previously it was known as seizure that lasts more than 30 minutes. However, the new classification defined as T1 and T2. T1 meaning that beyond that time, the seizure considered to be prolonged. And T2, beyond that time, the seizure will lead to long-term consequences. So for the tonic-clonic, it's 5 minutes to consider it as a status. When we reach a 30 minutes, so that will affect and cause long-term consequences. For focal aware seizure, the new terminology, or what's called previously epilepsia partialis continua, focal status epilepticus T1 is 10 minutes, and for the absence, 15 minutes. We have a lot of definitions regarding the status epilepticus. So we have impending status epilepticus, meaning in less than 5 minutes. We have established status epilepticus when we start the first line benzodiazepine already. The refractory status epilepticus when it is after starting the second line therapy. So what investigation we send for this patient? The most important thing to send for blood glucose to check if there is hypoglycemia because it might induce seizure, CBC, electrolyte, send anti-seizure drug levels if the patient known to have epilepsy, lactic acid toxicology screen, and CK, troponin, and sometimes LPF indicated. EEG is helpful to rule out non-convulsive seizure. So if the patient is convulsing clinically, then after that loss the level of consciousness, we might need EEG. CT brain to rule out any underlying space-occupying lesion, trauma, space-occupying lesion, or any epileptogenic epileptic foci. MRI more helpful sometimes to show if there is any focal cortical dysplasia or any underlying lesions. And the most important thing in management is early treatment. After stabilizing of the patient, treat the underlying cause, use benzo as soon as possible, and follow the treatment algorithm. So you should follow this algorithm. So in less than from 0 to 5 minutes, we should stabilizing the patient, assess the oxygenation, initiate the EKG, send for basic lab, secure IV line, and after that, if the seizure still continue, we should give between 5 to 20 minutes the benzodiazepine, so either intramuscular diazepam, and this is a single dose, intravenous lorazepam, this can be repeated once. Intravenous diazepam also can be repeated once, and all these benzos is per kg. If it is not available, we can give phenobarbital. If the seizure is still persistent after in 20 to 40 minutes, so at this time we should initiate the second line therapy, which is either phenytoin, valproic acid, or levetiracetam, and these are given as a single dose, 20 milligram per kg for phenytoin, 40 milligram and 60 for levetiracetam, with a maximum dose for each of these anti-seizure medication. If the seizure still continue, so at this time of point, we should refer the patient to ICU for intubation and starting sedation. With either midazolam, propofol, thiopental, or phenobarbital, even ketamine can be given to reach breath suppression pattern.